Diabetes monitoring isn't one size fits all. Today, we're clarifying A1C targets and picking the right monitoring tool for your patients. For most non-pregnant adults, the ADA recommends an A1C target below 7%. This is our baseline for reducing long-term complications. However, clinical judgment is key. For older adults or those with significant comorbidities, we loosen that target to below 8% to avoid overtreatment. On the other end, tighter goals near 6.5% may benefit newly diagnosed patients without cardiovascular disease if they can reach it safely without hypoglycemia. Now, let's talk tools. Self-monitoring of blood glucose, or SMBG, remains a clinical staple, especially for patients using insulin. Frequency depends entirely on the regimen. Basal-only patients might check once daily, while intensive regimens require pre-meal and bedtime checks. Continuous glucose monitoring, or CGM, is increasingly preferred, particularly for type 1 diabetes and type 2 patients on intensive insulin therapy. CGM tracks real-time trends and provides critical alerts for hypoglycemia or hyperglycemia, which drastically reduces the daily burden of fingersticks. Alongside A1C, we now prioritize time in range, specifically 70 to 180 milligrams per deciliter. This is a key metric for modern care. The clinical objective is to keep patients in that target range more than 70% of the time to ensure stable glycemic control. Here is your key exam point. Select CGM for patients with hypoglycemia unawareness, frequent lows, or significant glycemic variability. Always base your selection on the intensity of the insulin regimen and the patient's physical and cognitive capability to use the device. Know your individualized targets. Know the monitoring indications. Know the selection criteria for CGM. That's your pass. You've got this. See you in the next video.